Hey, good afternoon, everyone. Thank you for joining us today. We're about to get started in a minute. Oh, a lot of people trickling
I think we should play the Go New York, Go New York.
in.
Okay.
And before we get started, I just want to shout out the New York Knicks. I hope to see everyone at this call at the parade on Thursday. It's big time for New York. We got budgets. We got Knicks winning. Shout out to Liberty. They did it first, though. I got to see the Liberty Championship a couple years ago. So,
Well, it depends on when you start talking about wins first,
uh,
right? Because 53 years
in my
ago,
lifetime, yes, in
all
my
right,
lifetime.
it's all relative.
Yeah. But all right, we'll just jump right in. So once again, good afternoon, everyone, and thank you for joining us. My name is Jarrell Gray, and I'm the Assistant Director for Health Policy and Government Affairs at Public Health Solutions. We're excited to welcome you to the second edition of our Public Health Under Pressure series. So this series was created to bring important conversations directly to the community by convening experts to discuss key topics, trends, and policy decisions that not only impact our field, but most importantly, the people and communities that we serve. Today's webinar will be taking a timely look at the New York State budget, what it includes, what it means, and how it will affect our work moving forward. So to get us started, I'd like to welcome our President and CEO, Cassandra Howell, for our opening remarks.
All right. Thank you, Jarrell. Thank you for that introduction. Good afternoon, everyone. And thank you for joining us for the second event in our Public Health Under Pressure series. Public Health Solutions is New York City's largest public health nonprofit. And for nearly 70 years, we have worked to improve health outcomes for New Yorkers across all five boroughs. We are the largest administrator of WIC and the second largest administrator of SNAP in New York State. We also operate a robust health insurance assistance program with a strong focus on supporting older adults, people with disabilities, and individuals who are blind. Many of these essential programs have faced significant challenges due to changing federal policies, including the reinstatement of workforce requirements for able-bodied adults without dependents. According to the latest report from the Robin Hood Foundation, the proposed H.R. 1 SNAP cuts could push roughly 70,000 New York City residents into poverty each year between 2028 and 2034. At a time when public health systems across the country are already under strain, these federal decisions will have a far-reaching effect on states, municipalities, community organizations, and most importantly, the people who rely on these services the most. That is why Public Health Solutions remains committed to convening public health leaders, community members, government representatives, and advocates for timely and honest conversations about the future of our field. Today's discussion will examine critical funding decisions, identify service gaps, and explore how these policy choices will impact workforce capacity, community-based organizations, and the health outcomes of everyday New Yorkers. We will also connect state-level budget decisions to their real-world implications, looking at how these choices shape priorities in New York City and what they may signal for the future of local public health systems. Thank you again for joining us today. I look forward to hearing from our esteemed panelists and engaging in this important conversation together. And I'll pass it back over to Jarrell.
Yes, thank you, Cassandra, for helping us get things started. So before we begin, we're gonna just have a couple housekeeping notes. We're going to hear from four experts today. Each panelist will introduce himself, have about 10 minutes to share their perspective on the New York State budget. And after all presentations, we will move into a Q&A section with the audience. This webinar will be recorded and shared afterwards. And if you haven't already, please use the settings to turn on the captions to follow along. So first off, we will hear from Michael Kanukin from the Fiscal Policy Institute. Michael has already been digging into the numbers, and funny enough, we've actually been following the Fiscal Policy Institute's briefings to prepare for today. So we've been borderline stalking you for the past 2 weeks, but I'm especially excited to have him join. So, Michael, I'll turn it over to you. Please feel free to introduce yourself and get us started.
Thank you so much, Jarrell, and thank you all for being here to participate in this really important conversation. My name is Michael Kanuka, and I'm the Health Policy Director at the Fiscal Policy Institute, where I cover New York State healthcare, public health, Medicaid, and private insurance issues. And I'm going to just talk about the results of the state budget. Obviously, it was finally voted on and passed quite late. The enacted budget financial plan is recently out. And I'm going to talk about what that means for New York State's healthcare system and sort of where we go from here. But first, I want to set the context, right? So, from a healthcare perspective, this state budget happened in the context of massive federal cuts to Medicaid. Last summer, the federal government passed a bill, the so-called One Big Beautiful Bill Act, which was essentially a tax cut for the very wealthy, funded by very large cuts to Medicaid. Those cuts will be especially dramatic and impactful here in New York State because of our large immigrant population, which was specifically targeted, and because of our national leadership in expanding Medicaid benefits. On the other hand, coming into this state budget, we had strong revenue and moderate Medicaid enrollment growth. Our Medicaid enrollment in sort of mainstream low-income health insurance is back to where it was before the pandemic. And our enrollment in long-term care Medicaid has also flattened over the past year and a half. So the key drivers of increased Medicaid spending were not operative. And so what that meant is that we were in a position to face these federal challenges and to potentially address some of the federal cuts. And I want to talk about the federal cuts that are coming and what the state budget did and frankly what it failed to do about them. So I'm just sharing one graph here just to put this stuff in context. The One Big Beautiful Bill Act is a really massive threat to New York State insurance coverage and access. And the cut comes in really two waves. First, we are set to see dramatic essential plan coverage loss this July. In about 2 weeks, we project that 450,000 New Yorkers earning between 200 and 250% of the poverty line will lose essential plan coverage. And then a second wave will occur beginning this January. In January 1st, we'll see federally mandated Medicaid work requirements. And those work requirements will impose huge bureaucratic hurdles on folks trying to enroll in and maintain Medicaid coverage. Our evaluation is that most New Yorkers who are on Medicaid either already meet these work requirements or qualify for an exemption. But just because they're within the letter of the law doesn't mean they'll overcome the paperwork and red tape hurdles of demonstrating that to the federal government's satisfaction every 6 months. And so our expectation is that over the next 2 years, beginning January 1st, a further 800,000 New Yorkers are likely to lose health insurance coverage due to Medicaid cuts. All told, this graph tells the story. This is a graph of New York State health insurance coverage starting from before the ACA to today. And then the dotted line is sort of where we're headed as these federal cuts phase in. We can see we made enormous progress in insurance coverage because of the Affordable Care Act. And we are likely to see the reversal of most of that progress over the next year and a half as cuts phase in, beginning again in just 2 weeks with essential plan loss. So it's a real tragedy. Coming into this budget, advocates were really hoping that the state legislature and the governor would take action to prevent or mitigate some of these losses. Unfortunately, that did not happen. And so these cuts are likely to go into effect and are going to be really, really impactful, especially here in New York City, where many, many residents rely on these programs. We're expecting the uninsurance rate to roughly double here. So what did happen in the state budget if insurance coverage loss was not addressed? Policymakers chose to spend money elsewhere. So this is not a budget that is full of healthcare cuts, right? In fact, Medicaid spending is set to increase very substantially by, depending on how you want to count it, about 8 or 9%. But the new spending is not going to mitigate health insurance coverage losses. Where it is focused is on provider rates, and especially hospital and nursing home rates. The hospitals and nursing homes in New York have been financially struggling for a while. They're likely to see additional pressure due to these coverage losses. And because of that pressure, and the policymakers elected to give them rate increases totaling around $2 billion, sort of all in. Most of that is, the vast majority is just sort of overall Medicaid reimbursement rate increases, which are not especially targeted to safety net providers, but they will help support safety net providers. And so the big outcome for the budget is just that. The policy decision to sort of focus healthcare spending on providers and not on preserving health insurance access. A couple of other key spending initiatives. New York City saw its Article 6 public health funding restored to previous levels, valued at around $90 million. That is likely to support New York City's public health initiatives through DOHMH, but really primarily is about relieving fiscal pressure on the city, which was a key issue in this budget. We also saw a cost of living increase across the board for mental health providers in what are now nicknamed the O agencies, OPWDD, OMH, and so OAS, AS, and so forth. Unfortunately, that COLA did exclude the public health workforce, but even with that exclusion, it was a $280 million increase. But big picture, what we're looking at is a really massive health insurance loss. And so what does this mean for the future of healthcare in New York City? There are sort of two issues. One, the folks who are losing health insurance coverage from public sources are not likely to see coverage restored through private sources. New York City is one of the most expensive health insurance markets in the country. It costs about $12,000 a year to insure a single individual through the private market. And so what we're seeing is really a double crisis of health insurance access in the public and the private market. That will generate increased pressure on safety net providers, on households, and there's an open question of what the politics of that will look like in future budgets. And then the second thing I'd say is that these coverage losses and also additional federal cuts that are set to phase in over the next 2 years will be really, really impactful on safety net hospitals, including health and hospitals and other private safety nets in the city and statewide. In the state so far, due to strong revenue growth, has been able to kick the can on sort of the crisis that's emerging in our safety net hospitals. But in the long term, the state legislature and the governor will need to find a way to either make these hospitals sustainable or acknowledge that they're not interested in sustaining them. And so those are two open questions as we go into the next budget. And with that, I will kick it back to Jarrell.
Yes, Michael. Thank you for joining us. There was people already asking for your slides. I do want to point out that Michael actively is presenting with the Fiscal Policy Institute, so there are already some webinars that are up on YouTube. But we'll be sure to get those slides to you right after. But thank you again for joining us, and I know people already have questions lined up for you, Michael. So next, we'll hear from Brooklyn Assembly Member Farrah Souffrant Forrest. Assembly Member Souffrant Forrest has been a big partner to Public Health Solutions over the years and also a leading advocate for maternal health. She was on the ground in Albany as the budget was being deliberated and negotiated as a member of the Health Committee, Insurance Committee, Social Services Committee, and a plethora of other committees. So, Assemblymember, I'd love to pass it off to you to share your insights. Many of us are eager to hear your perspective, particularly around your priorities heading into the budget season, the challenges that you and your legislator faced, what felt feasible, what didn't make it into the final budget, and what all of this means for New Yorkers. So, I'll pass it off to you now.
Thank you so much, Jarrell. I also want to say thank you to President Howell for this invitation to speak today. And, it's always fun with my friends over here at PHS. I am Farrah Forrest. I'm the Assembly Member for 8057, covering Fort Greene, Clinton Hill, Crown Heights, and Bed-Stuy. I am also a registered nurse. I am so happy to be here with Dr. Appointe, my former boss over at Borinquen. It's always good. I'm telling you, you're all friends here. And so I really can't say, Michael's overview of what happened in the legislature in the context of the HR1 bill, the failure called HR1, really it's not a bright light in our world here in New York State. And it's not, I'm not going to be here to bring on the great stuff, but because it kind of goes down further worse than where he said it. So as a legislator who is fundamentally committed to making sure that New Yorkers live a dignified life, the budget attempted to do a lot for in other spaces, and I'll talk about those spaces, but we failed when it came down to just making sure that New Yorkers remain safe and healthy in their homes. So let's start off with where we did all right. Like I said, like Mike said, we didn't do a lot in health, but we did attempt to do some other stuff in social services. Some important things that were added, as Michael had said, there was a 2.7% increase for COLA for essential human service workers, but that did exclude healthcare workers. We did do some more increases in terms of helping people who use SCREET and DREE. For years, I was going to say decades, we were stuck at the limit of 75K, 50K, now we're up to 75K. So people who make a little bit more can actually benefit from freezing their rent and or people who are older and have disabilities. We also did some money for the Housing Access Voucher Program. The original ask was $250 million, but we did get 50. So that's something. And then we got $140 million, that's an M, for NYCHA, knowing that we actually need billions. We also did some, we bolstered up SNAP benefits because we knew that the work requirements were going to kick off a lot of people. And so we did $26.4 million for services expenses related to providing nutritional supports and providing nutritional education to pregnant women, the WIC program. Okay. And then we also did $8.7 million for the nutritional outreach and education program. And then we did some initial investments into the 2K program. Now, again, remember, this is restricted to the municipality of New York City, but we'll get to the rest of the state later. Okay. So those were some of the stuff that, on paper, it sounds like we did. But I'm telling you, as someone who joins others, the other people in the legislature, people really do care. And what we did want was things like, and they weren't included in the final budget was no funding to preserve the essential plan. So that means July 1st, there will be 450,000 people, maybe a little bit more, that will be kicked off the essential plan and they will lose coverage. We had some money that we, under the chair, Pauline Bill, who is chair of health, and also Senator Gustavo Rivera. They had a bill also to move $2.4 billion into covering that gap. The reason why they said they didn't want to put it in, eventually the executive said she didn't want to put it in, is because a year is not enough to do anything. So whether it's now or later, they're going to be dropped off. Okay. And then also we had no funding for gender affirming care, no action on fair pricing to protect patients from price gouging in terms of price fixing in terms of medical bills, and no state funded SNAP to fill gaps for those who will lose their coverage, and no additional funding for WIC. It was a lot to have a budget that was due 57, that was delivered 57 days late, really was discouraging as a legislator. I can't really tell you that I spent most of my time, really, fighting out there and pushing the envelope, because honestly, we did our one house, and that's where, as legislators, we get to put in our voices, and then we hand it to Carl and we say, okay, our speaker, Carl Hasey, and say, look, Carl, you go carry this and, relay race it to the end. But, at the end of the day, with the balance of power the way it is, it lies heavily in the executive's hand. And so, one of the ways that this had, really affected us is because the budget was so extended. When we as legislators, we have a discretionary funding, which many of you are familiar with. We were able to get $250,000 this year. This is where members get to pick unique organizations within their districts to really, support where the budget might have fell short. But because we did not have a budget that was delivered on time, our discretionary funding time was eaten up into the budget. And so we had to make sure we put in our line items, but we didn't know exactly what was going to be funded. So I think that there will be some, fallouts on that. But, I do suggest certain tactics for CBOs. Please engage with your funding agencies early on. Budget really does start in June. So while the legislative session just ended, I do encourage you to reach out to OTDA, OCFS, reach out to OMH, and get in your numbers so that way when the agencies are properly lobbied by you, they can then take their numbers and their need of the community to the executive by November so that she can include what needs to be included to make the community whole by November. And then also I will say that this year we failed to tax the rich because that revenue would have been what would have been able to fund our communities. I do know that our speaker has spoken multiple times about next year is going to be different, but the only way it's going to be different is if we say it's going to be different. So I encourage everyone individually and in your respective organizations to speak up and make sure we get the budget that we deserve. Thank you.
Yes, Assembly Member. Thank you for sharing all of those updates. Do you want to, because I've seen that you started speaking about CBOs. Do you want to let all of the CBOs on the call know about the webinar that you host?
Oh, yes. So there's a lot of like gray spaces around what is discretionary funding, how you get it. Um, I do have a webinar that I would love to make available to you. I will drop my email in the inbox. It is the formula that my office uses, but the overall process is the same for the entire state. So I'll share it, and I hope that it'll be a useful resource to you all. Thank you.
Awesome. Thank you so much. And you were on time with your remarks. You were doing real good today. Next up, you see at PHS, we're efficient. We're making sure that the information gets to everyone who's attended. We'll make sure that the slides will be sent out after. But we're also on time and we're leaving space for questions and answers. So with that, next up, we'll bring up Dr. Adam Aponte. Uh, Dr. Aponte, could you please introduce yourself and share how this New York State budget will impact your work as the CEO of East Harlem Council for Human Services, including the oversight of the Puerto Rican Health Center and the communities that you serve?
Great, great. Well, thank you very much, and so happy to be a part of this panel. Thank you for PHS for putting this together. Of course, my girl Cassandra Howe holding it down there now at PHS. We're very proud of her and all the work that she's accomplishing, and kudos to my colleagues who have shared their comments. So my name is Dr. Adam Aponte. I am the CEO for the East Harlem Council for Human Services. We are a non-for-profit based in East Harlem, and we've been around since 1965, so 61 years. For those of you who are at our gala a month ago, saw how we turn up. And we have several programs under our umbrella. I'll mention the programs, but I'll focus on the Borinquen Neighborhood Health Center. So we have one of New York City's very first bilingual Head Start programs since 1969. We've been doing Head Start. We have school-based health center programs. And then we have a program funded by DIFTA for our older adults. By the way, that's the new terminology for older adults. They don't like to be called seniors anymore. Or at my health center or at my center, they like to be called recycled teenagers. That's the affectionate term for each other. And the crown jewel of the East Harlem Council, however, is the Borinquen Neighborhood Health Center located in East Harlem, New York on 123rd and 3rd. We've been around since 1974, servicing the East Harlem and surrounding communities. It is a federally qualified health center, and make sure that your viewers know what FQACs are. You'll hear me use that term quite often, but we are a group of safety net providers. Michael mentioned safety net providers. We are it. And we provide care to anyone who crosses our threshold, regardless of their ability to pay, regardless of their insurance status or any other factor. And so when large Medicaid populations, we serve generally underserved populations. In New York State, there are about 80 FQACs with 900 locations serving 2.5 million New Yorkers. That means that 1 in 8 New Yorkers get their care at FQHC. So I'm going to give you a very I guess my view of what this bill has done or this budget is doing for FQHCs. But as I said, we work with 2.5 million New Yorkers. So as you can see, the impact is going to be significant when it comes to this. So we talked about HR 1, and that's the way we should refer to that bill. There's nothing beautiful about that bill. So I never refer to it in those letters. That's a bunch of, just rhetoric. This is HR 1. And the Medicaid requirements that are changing that Michael outlined earlier are indeed going into effect, including Essential Plan. Essential Plan patients are patients who are about 200 to 250% of the federal poverty level. We don't have a lot of those patients in FQHCs. We estimate across the state about 85,000, but nonetheless, those individuals become uninsured. And where will they seek care? Very likely they'll be coming to FQHCs like ours because, as I mentioned, we see anyone regardless of their ability to pay. So there's going to be increases in uninsured patients coming to us. Most of us are seeing, probably about 10, 11, 12% uninsured rates. We're going to see those rates go higher. And that's an important factor to remember as we talk about the budget. The FQACs of New York, estimated that with these changes to HR 1, FQACs collectively across the state will lose about $300 million in revenue across all of us. Obviously, individually, it may differ, but across the state. So for this budget, we were advocating strongly for some assistance from the state in terms of mitigating that $300 million loss. And we asked for that $300 million. And unfortunately, or maybe fortunately, depends on how you want to look at it, we did not get the ask, but we did get some recognition within the state budget that I'll sort of allude to. But that $300 million is not a handout or giveaway. It's to really help mitigate these losses and the increases that we anticipate to uninsured patients coming to our health centers. So that was one of the asks that we put in. At the end of it, each branch had proposals. The executive branch offered $60 million of relief. The Assembly offered $80 million, and the Senate offered 100. At the end of the budget cycle, $80 million was allocated to FQHCs. And the good news about it is that it is $80 million. And the other further good news about it is that it's dedicated strictly to community health centers, FQHCs. Michael talked about relief to hospitals and nursing homes. That relief was not provided to FQHCs under the $2 billion that he was talking about. That strictly goes to hospitals and nursing homes. So we needed some support. By the way, I want to remind folks that FQHCs today, our rates are based upon 1999 cost factors. So we're already struggling with reimbursement rates that are antiquated. Think about a quart of milk in 1999 and what a quart of milk cost you yesterday, and you can sort of understand the challenges, how we're getting about 70 cents on a dollar at this present time. So that was something that is very significant to us. We needed that assistance just to make sure that we can handle the new uninsured. We didn't even talk about rate reform, which is something else that we're advocating for. We also have a couple other things in this bill that were impactful to us. One of the programs that we offer to our patients is called the 340B program. For those of you not familiar, it is a pharmacy program whereby we're able to receive pharmaceutical agents for our patients at cost, and then pass that savings on to our patients who are uninsured or underinsured. An underinsured patient, by the way, is a patient who has insurance but doesn't have full coverage and has a lot of out-of-pocket expenses. Uninsured is pretty obvious. And so a lot of pharma now has been trying to impact our ability to capitalize and use get those 340B revenues, which, by the way, we use to reinvest and create programs. There's a lot of things that FQHCs do that are not funded. Our care management, our patient navigation, some of us has food pantries. There's a whole host of different things that we do with those monies from the 340B revenue that help to really bring care to our patients. We try to be very patient-centered, and those monies help to support those programs. And without that funding, some of these FQHCs may have to pull back on some of these programs. The other one that we were looking for is something called telehealth parity. We all know when COVID hit, everyone was using telehealth, right? And it was an amazing way to get health to people without having to come into the health center. Well, today, if I render a telehealth visit, and my provider and my patient are not at the health center, I'm only given a third of my reimbursement rate. That provider does not cost us any less. And we've been trying to really push this, what we call telehealth parity for Article 28. That's what we're licensed as New York State with that. Article 31's mental health providers get their full rate of reimbursement. And so there's a really misalignment with the priorities around that. And then we're trying, challenging for us, and I'll close on this point, is staffing for FQHCs, right? We're in underserved communities. We're not the sexiest job out there, although the most meaningful job, I would dare say, because of the work that we do. But recruiting nurses and doctors is always a challenge. And one of the ways to mitigate this, particularly for my upstate colleagues around nursing recruitment, and you heard from our assembly member who's a nurse, is using medical assistants as vaccinators, allowing them to really work at the top of their license so that they're allowed to vaccinate, and letting our nurses do more higher level patient education and patient care things that they don't, they typically, are divided amongst. And so that was something else that we were looking for in this budget that has impacted us. So all in all, while we did get the $80 million for community health centers, there's still a lot more work that has to be done, because all of those uninsured patients that you're hearing about, all those individuals that are likely to fall off the Medicaid roster, which, by the way, we're going to do a lot of work to help people not fall off Medicaid roster, but that's going to cost us as well. They're going to be seeking care at the community health centers. And so how are we going to be able to handle all of those new patients, all those uninsured patients when, funding has not been tied to that new influx of patients, and there's no increase in charitable pool dollars that so far as we know. So those are the things that impacting community health centers in New York State. And so I'll close out on that and happy to answer questions further along. Thank you very much.
Yes, Dr. Aponte, thank you so much for joining us and also just sharing your perspective and the work that you do. I think it was very important to highlight just the not discrepancy, but the to focus in on like the community health center aspect, right? And how some of the more localized, trusted partners where people are going to be seeking care will be impacted by the state budget. And with that, that's a perfect transition to Veronica Smith, Senior Director of Health Policy and Government Affairs, my boss at Public Health Solutions. Veronica and our team has been deeply engaged in advocacy throughout this budget process over the past several months. And I want to turn it over to her to share what she's seen, what the budget may mean for New Yorkers going forward.
All right. I am not Jarrell's boss. He's our teammate. I like to use the word teammate, colleague, friend, and as long with everybody here at PHS. Good afternoon, everybody. My name is Veronica Smith. I am the Senior Director of Health Policy and Government Affairs for PHS. I am a born and bred New Yorker, proud Brooklyn girl from Sunset Park, that is a daughter of immigrants from Ecuador and from Dominican Republic. And New York City is my favorite place in the world. So working for an organization that is meant to uplift our people to just give them a better chance so that they can have dignified lives is incredibly important to me and to everybody on this screen and everybody at PHS, starting with our fearless CEO, Cassandra Howell. I will be talking about the impacts on the community and how PHS has advanced our advocacy goals throughout the session and just in general here at PHS. Our strategy is quite simple. Our strategy is very much in the vein of being proactive, community-centered, and focused on building partnerships that aim to advance the health equity of all New Yorkers. And as you heard here with the other panelists, this was a very disappointing budget. But at the state level, we did try to advance an ambitious city and state advocacy agenda to support underserved New Yorkers. PHS conducted about 21 budget advocacy briefings with legislators and health policy staff to advance our fiscal year 27 priorities that included a targeted inflationary increase, or TII. It's the new fancy word for a COLA, for the entire community-based public health workforce. We advocated, along with the New York State WIC Association, for increased funding for WIC, $30 million in increased funding for WIC providers, so that we could increase operations or streamline operations and make them more efficient so that we would be able to reach all of the eligible participants that had not yet enrolled in WIC. And we also were advocating for specific stopgap funding in the number of $115,000 for SNAP. PHS is the second largest administrator of SNAP in the state. And earlier this year, we were informed by OTDA that our 5-year contract, I'm sorry, there's like some ambulances around, but can you all hear me? Everybody's fine? Great. So the stopgap funding that we were requesting was to serve as a bridge, because the targeted SNAP program ended 1 year early due to HR 1, the horrible bill. And we were concerned that there would be some some coverage loss for SNAP recipients, especially with all of the changes that are being effectuated due to HR 1 with the SNAP ABOD requirements and with the upcoming Medicaid recertification requirements. So there was a new RFP that the state released called the Nutrition Navigator Program that was meant to replace the TSNAP program, but we do not know when that will be awarded. We do not know whether PHS will receive the same amount of funding, and if we are going to be awarded. So we took a proactive step and reached out to our legislators and advocated for that stopgap funding to cover us through the last quarter of 2026, just so that we can ensure that all of our SNAP participants continue to get the benefits that they deserve. Then we also advocated for the $30 million of the proposed public benefit assistance program. And unfortunately, that was not included in the budget. And to advance these priorities, these efforts, they strengthened relationships with the elected officials and with the community-based public health workforce. But the legislative session really did conclude with very limited new investments in public health. The final state budget included a 2.7% targeted inflationary increase, as Assemblymember Forrest mentioned. But as she delineated, it did not include the entire community-based public health workforce. So that is something that a lot of the CBOs that are part of the Human Services Council and the Just Pay campaign, of which we are a strong partner of, were very, very disappointed to see that while the increase was included, it doesn't impact everyone. Additionally, most of our existing contracts remained level funded, and two federally funded programs that we were monitoring were WIC and SNAP. WIC also did not receive the $30 million of additional funding that had been proposed from the New York State WIC Association. So unfortunately, like I said, it was a disappointing legislative session, but we will continue, and we are even more committed to making sure that our communities get the funding they deserve. One little point on WIC that I would want to stress. Public Health Solutions, we are the largest provider of WIC in New York State. We have 9 WIC locations throughout Manhattan, Brooklyn, and Queens. We have 5 locations in Queens, 3 in Brooklyn, and 1 in the Bronx. And in 2025, we supported over 500 plus families and their infants with additional maternal and child health support, such as breastfeeding warm line support, parenting support. And in 2025, we provided over 31,000 participants with WIC nutrition benefits. Now, for SNAP, as I mentioned as well, we are the second largest provider of SNAP in the state, and we focus on the most food insecure locations, including East Harlem, the Bronx, Jamaica, Southeast Queens, Corona, Elmhurst, Central Queens, Flatbush, and Southern Brooklyn. And we reach young children and our recycled teenagers as well. Additionally, our small team in just 1 year has been able to provide over 14,000 individuals and distributed approximately $1.9 million in SNAP benefits. That is a huge number, and we are a small and mighty team, but we are embedded in all of our communities. We speak about 16 different languages, and the folks that come into our office are seeing folks that look like them, that are their aunties, that are their cousins, that are their neighborhood friends. So there's a level of trust that we have built over 69 years. Now, one really wonderful advantage that the state budget was able to introduce and was a result of a lot of advocacy was the transition to EBT cards to enable new chip technology to ensure that folks do not get their benefits stolen. That is a huge issue across New York City, SNAP skimming, where you have folks that will go to the store, go to the supermarket with their card, and it has their name, and they have nothing on their card. And that is something that's pretty unconscionable. So that is something that the governor's office and the legislature made sure to include in the final budget. I will take just 2 more minutes just to talk about the lack of proposed public benefit enrollment grant funding. That was supposed to be $30 million for entities, CBOs across New York State that would provide public benefits, and that was not included. However, the bright light is that the legislature and the governor did include $90 million in discretionary funding for community-based organizations through 3 caucuses: the Black Caucus, the Hispanic Caucus, and the Asian Caucus. So each of those caucuses will be receiving $30 million that community-based organizations can apply to support priority programs and services. Now, more broadly, in 2025, PHS served over 300,000 community members, and we don't do that alone. We do that with partners such as Dr. Anima Ponte, with partners such as Assemblywoman Ferris Front Forest. And we will continue to do that moving forward. And for our next session, for the next FY28 session, we will continue to advocate for the community-based public health workforce so that their TII, their COLA, is restored, because that is something that they had received previously. But during the Cuomo administration, that unfortunately was removed from negotiations, and it was always meant to be restored. But we are now over a decade later, and this community that is helping the community, that is the workforce, that is the pipeline, really, really needs the support, and it's going to be even more stressed with all of the changes that HR 1 has coming down the pike, and it's going to fall on to the community-based public health workforce to help shepherd community members through that process. So we need to make sure that we do right by them.
Yes, thank you for that, Veronica. And the point that you just ended on is probably going to be the first point that we bring up in the Q&A. But I do want to thank everyone for sticking with us, right? We just are about to hit the 50-minute mark, and we're still at over 170 participants strong. Can you mute yourself, please?
Mhm.
Yeah, over 170 participants strong. So I'm just going to give everyone about 30 seconds to put some more questions in the chat, and then we're bringing back all of our panelists to answer some of these questions. Assembly member.
I wanted to say something while our invitees are percolating. But between Veronica, Dr. Ponte, and Mike and I, our presentations, if you haven't gotten yet how bleak the landscape is around healthcare right now. I know we say some people will be dropped off or services will be cut, but it was very important for me as a nurse to explain that it's not just, oh, cute cuts, like, oh, we might not have just the, yoga class today at the BMS Center. We're talking about massive cuts where operationally, facilities-wise, we will not be able to address the needs of, we already know the number is 450,000, but we know that it will be more because these 450,000 people are attached to families and communities. So, I mean, the way I described it in the legislature, we have conference where we have private conversations. I've said there will be dead babies and dead mothers. That is what the results of these cuts will be. And so even if you're sitting there in your, office, or, if you're working from home, you're on the Zoom, whatever, you're like, well, I don't know. No, you do know, because you know what you do, whether you're in HR, whether you're working with frontline staff, one more patient on that panel, or one more client walking in through the doors looking for SNAP or WIC, or a job, or they need referrals. You don't have room for one more. So I don't know. If we tell you there will be 100 more, you make the math. It's not math. Okay, thank you.
Dr.
Yeah,
Aponte?
Jared, if I could just piggyback off what the assembly member just shared. Sometimes people will hear this and they think it's hyperbole. They think it's exaggerations about what we're talking about. But imagine 450,000 people just losing coverage from one day to the next, and where they're going to turn to, and losing their doctors. And that's just the tip of the iceberg, to the assembly member's point. Programs will close. Community health centers cannot sustain these additional uninsured patients without some kind of compensation to support the staffing required. So when you talk about capacity is going to decrease. And that's going to force patients into one of the most expensive places to get healthcare, and that's the emergency rooms and urgent care. And those are not places to get primary care. And so it's really somewhat backwards thinking when you think about how patients are going to be forced into those settings, which are actually going to increase the cost of healthcare, not decrease the cost of healthcare. It is much cheaper to send a patient to my community health center than to send a patient to an emergency room or urgent care. And that's where we struggle with these decisions that are being made and not realizing the trickle-down effect that they're going to have.
Go ahead.
So Dr. Ponte and Assemblywoman are 100% right. And I want to give folks they're still joining us just a real world example. I know of a friend of mine that is a parking garage attendant, and he and his wife were lawyers back in Ecuador, but their degrees don't count over here. So he's a parking attendant. His wife is a social worker, and they both make around $40,000 a year. They have 2 children, and because they don't qualify for Medicaid, that they can't afford private insurance. Now with these changes, because they are in that bucket, their health insurance is too unaffordable, and they're not going to be able to pay it. So now they have chosen to forego insurance, and their children who are under 18 don't have insurance. That is the real world impact of what is happening. These are working people that are losing insurance. I don't want folks to think that it's just, these are handouts, these are this, these are that. It's not. Even if you have private insurance, you're going to feel this, because the plans, the hospitals are not going to absorb the cost. They're going to take it, they're going to pass that cost down on to the consumer, which is all of us. And it is much more practical, aside from it being an ethical point, but it's just more cost effective to make sure that people are taken care of before it becomes an emergency rather than after, which is why the social care network and the 1115 Medicaid waiver program is so critical, and why we want to make sure that that remains past the waiver period. I know that there were some questions in the chat about the social care network program, and for everyone's general awareness, this is the New York Health Equity Reform Initiative. It's a demonstration project that is meant to address the social drivers of health, which is things like access to food and access to housing and transportation. And the thought process is that if you don't know when you're going to eat again, if you don't know how you're going to pay rent, and if you can't even get to your primary care doctor, how realistic is it that you're going to take care of yourself when you start kind of feeling, high blood pressure, symptoms, when you start feeling a bit woozy, when your diabetes starts to get under control? You're not going to do it, because you have more acute priorities to take care of. And your symptoms and your illnesses do not go away. They're going to get aggravated, and you're going to end up in the ER. And it could be worse when it could have been prevented had you gotten that preventative care. And finally, Medicaid has wised up to the fact that, health is not just in the doctor's office. Health is holistic. Health is the whole person. And that includes making sure that people have food in their belly, a roof over their head, and a way to get access to health services.
So I do want to turn our attention. We definitely have a ton of questions flowing in. I seen that Dr. Aponte started to answer this one, but this is from Marta Rieger. Can you inform us of the role of community health workers, especially navigators that help people who have difficulty accessing both primary and social care health services? Has there been enough advocacy that funding these roles are fiscally responsible?
Yes, so I'll piggyback on what I said. So I started answering that question in the chat, but so community health workers for the very first time are now we're allowed to bill for their services. For those of you who are not aware what CHWs do, but they do help patients to navigate, keep them engaged in the healthcare system. Many of us were hiring CHWs and with no reimbursement tied to it whatsoever. As of late, there has been some reimbursement and recognition of the importance of having individuals like that. They can also serve as patient navigators. The bottom line is we have a very complicated healthcare system. I don't care what your educational attainment is. When you're dealing with multiple chronic conditions and you're trying to navigate this healthcare system of ours, any one of us can get lost. And so to have CHWs available to help folks navigate and be more patient-centered has been recognized as a very valuable tool. And finally, there is some reimbursement tied to it. We like to see more of that, but we're happy with that progress.
I guess I have a question then, kind of turning around a little bit. Maybe Veronica and Dr. Ponte can help, like, for me. When you have patient navigators and when they navigate and they send somebody somewhere, then how does that get affected? Because I know we cut a lot of places, so
So for us, the navigators, what they do is they help patients get to mostly, a lot of times they're specialty referrals, right? And so if you have a patient, you know this as a nurse, you're a diabetic, you're going to see a bunch of ologists, right? You're going to see the podiatrist, you're going to see the optometrist, you're going to see the nephrologist. And some patients have really big, significant challenges navigating, getting to that appointment, particularly if the English is a second language or they're recent immigrants to the country or they're scared, right? You get a woman who's recently diagnosed with a lump on her breast on a mammo. They start to become very fearful and they'll delay care further. So the patient navigators help to get those patients to and from the facilities, help them to make sure that they can, get there, get the information back to us and ensure that they get the care they need. Patient navigators purely are not reimbursed. Community health workers that can do patient navigators are reimbursed, but the patient stays tied to us in terms of primary care. Rarely are we transferring them for a different level of care to another facility for total care. It's usually for those specialty care needs.
a question that came up during the budget process is also full ability for nurse practitioners and also
PAs,
physician assistants
physician
to
assistants.
work.
Yes.
Now, different disciplines might be whatever they want to feel. But what I'm saying is that the reason why I bring this up is because when you have patients now not getting preventative care and they're forced to then be seeking secondary and tertiary level of interventions and care, then you're going straight to the specialist. Now, I know some of you may know, but before you even see the endocrinologist, you'll see it in the PA, you're seeing the NP, even if you do get that appointment within 3 weeks. But for you to actually see the endocrinologist, you're waiting at least 4 months. So, as we navigate patients through this system and counsel them and help them get there to the care that they need, be aware that the legislature had an opportunity to ease that burden, to expand access, but we didn't do it. Not we, don't say me. She didn't do it. Okay, let's
All right.
go.
So I wanna also just kind of add on to what Dr. Aponte said regarding the community health workers. At the city level, we definitely have made some progress through our campaign along with the Human Services Council, the Just Pay campaign. About 2 years ago, we secured a 3% COLA for 3 years for city workers that include community health workers that are providing human services to city residents. So that is something that was a fantastic achievement that Speaker Adrian Adams, along with former Mayor Eric Adams, were able to negotiate, and we are calling for a continuation of that. Additionally, at the city level, we just participated with, I think, over 200 or so brothers and sisters from the human services sector for a rally to call for the passage of a wage equity bill that Council Member Althea Stevens is pushing, that would basically ensure that there's parity between the titles of the different community health workers and the navigators and the counselors and so on, so that there's parity. We'll make sure to put those bills in the chat. And then at the state level, I would be remiss if I did not shout out the fantastic State Senator Roxanne Prasad and the fantastic State Assemblyman Andrew Hevesy, who have been at the forefront of pushing bills that would ensure that the entire community-based workforce, public health workforce, is included, and the entire human services sector has their TIA COLA restored. So we'll make sure to put those bills in the chat as well. But I think that there was a bunch of questions about the SCN. So I will try to take one question that jumped out at me. Does this mean that CBO providers currently delivering HRSN, health-related social needs services, will have no alternative options for serving these patients if the waiver is not renewed? I think that's a hard question to answer. What I will say is that whole UNYC at PHS is the infrastructure network that was created to be able to manage this program. Now, if for the SCN, this is for Medicaid members. If you are not a Medicaid member, and if you are not part of a certain eligibility category, like having a chronic health condition, like having diabetes, being under the age of 18, somebody that was formerly part of the criminal justice system, you would not be eligible for those health-related social needs. However, you are screened to determine what social needs you need support with. And you will be referred to and navigated to the existing state and local resources that all of the community-based organizations that we know and love have been providing services for decades. So even if you are a Medicaid patient or not, as long as you get screened, we will identify what you need support. We will ask you what you need support with. And if you are qualified and are eligible to receive services through the enhanced services for Medicaid eligible populations, you'll get those services. But if you still need services and you're not Medicaid eligible, you will be directed to all of the other existing services that are available at the state, city, and local level. So we're not leaving anyone in the lurch. We want to make sure that people have access and that people are directed to services and ensure that those connections are made. That's the really unique part of the social care network program. No one can get paid for services until it has been confirmed that there has been a closed loop referral. Meaning that it's one thing to get information, it's another thing to ensure that the participant, that the client received those services and is satisfied with those services. So that is another key feature of the program, and everyone that's part of this program, including over 200 community-based organizations. Just in PHS alone, we cover Manhattan, Brooklyn, Queens, but Somos covers the Bronx. Staten Island PPS covers Staten Island, and then there are several other SCNs that cover the rest of the New York State region. We'll be calling for, continued funding so that we can keep this program going and that we can kind of make this, standard care. This should be best practice anyway, right? So we need more time to demonstrate that this is working because it does work. And we just want the opportunity to continue ramping up and making sure that we serve everybody that needs that support.
Thank you for that. Michael, are there any questions that's poking at you that you feel like you want to jump in and just do?
Someone asked about OPWDD, NHTD, TBI, and home care. These are Medicaid services for folks with various disabilities, physical or intellectual, developmental. HR1 does not directly cut those services, but we have seen an escalation of federal attacks against those services under the banner of fraud. The federal government has actually cut off Medicaid funding for aspects of California's Medicaid system and looks likely to try similar things against New York. So that's definitely something to watch. In terms of this state budget, we did not see a lot of movement on any of those programs. The governor has been threatening to administratively cap NHTD, and it's not clear to me whether that is going forward or where those conversations are. But this was a very sort of hospitals and acute care focused Medicaid budget.
Thank you. And this is going to be our last question, but I'm going to edit it a bit. What would be the one most important specific thing that you would ask of the New York State Senate, I believe referring to the legislator regarding these issues? And Assembly member, you started talking about it at the end of your remarks. But I guess for the CBOs, advocates, organizations on this line, what is this budget signaling for the next upcoming budget process, and how should we start preparing to tackle it? What's ahead? And this is for anyone that's on the call, any of our panelists.
Well, we got to get the work done, right? I mean, we have started a process and we got to continue to move our legislators. The Assembly members said it well, right? This session is over, but the work still begins. Now your Assembly members will be back in the districts. You should be visiting their offices, planting stuff in their ears, making sure that they're well informed. Some are not as steeped in these issues as our Assembly member on this call, so don't assume that they understand the issues and how they're impacting it. Use patient testimonials. We just got to make noise, right? We got to make good trouble. And everyone's voice counts. Don't think it does not. Folks are listening, and be a part of the solution, not a part of the problem.
Like Dr. Ponte is right. The work still continues. I will say this because I know some of the CBOs, if you are showing up to Albany in February for caucus weekend, you're too late. I'm just telling you that right now. Showing up to Albany is too late. Somos, you might make it. You kind of late, but it starts now. The summer does not mean take off. Meet with us. But then also use your respective councils. I know there's people with different unions, different CBOs are part of different networks. Use those networks to meet with legislators, with caucuses, task forces still meet. For example, if you are a network around immigration, my office is still open as the chair of the task force of New Americans. So if you want to talk about something related to immigration, call me because I'm still working. I still get a paycheck over the summer. So I'm telling you, June to November, October, that is the time for you to be hitting the pavement. If you wait till caucus, you're just there for the parties. You're not there for nothing serious.
Michael, any closing remarks?
This session was real lesson for me in what Assembly Member Souffrant just said it's really the squeaky wheel gets the oil, and we should not assume that legislators are going to listen to numbers or that they're going to understand numbers. They really have an endless capacity to be like present company excluded, to be like, oh, in my district I haven't heard about that. What? That's the first thing I'm hearing, so just for those of us who are really in the weeds about this stuff, it's easy to assume that if you're a state legislator and it's your job to know about this stuff, you're going to know about it, but they really will not know unless we're in their faces.
And I can provide a real world example for the community-based public health workforce. For 3 years ago, the majority of the elected officials didn't even know that they didn't receive a COLA. They assumed they did. Okay. So a lot of that legislative session, FY25, was educating members and saying, actually, no, they never got their COLA and they never got the healthcare worker bonus because the programs weren't funded by Medicaid. So it is 100% true that these elected officials, the amount of information the assembly members receiving is massive. It really is on us to make sure to share that information and highlight what's important to you. And I would like to just say to everybody on the call, we are resilient. There are more of us than them. They've shown us what they can do. Now it's time for us to respond. We have power in organizing. Everybody here is committed to helping people and making sure people can live a dignified life. So now it's up to us to organize and to make sure that we are collaborating and joining forces and demand that these changes are made. That's it.
And on that note, I want to thank all of our panelists for, oh, Dr. Ponte, I seen you unmuted.
No, I just want to just sort of echo that what Veronica just said, that it may seem like a lot of dismay right now, but we have been doing this for 61 years. We're going to outlive this administration, and we just have to pick up the pieces at the end of it all when it comes to HR1. And we always find ways to pivot and continue the work that we're doing, despite the challenges that get thrown in front of us. So I echo those sentiments. This is not the time to curl up in a ball in the fetal position. This is a time to really get out there and make some noise, and this is a platform that allows us to do that. So thank you, Public Health Solutions, for allowing this dialogue.
Good trouble.
So thank you to our panelists for this discussion. It was very thoughtful and engaging. And to all of our attendees for staying with us through the discussion. Waiting for the budget to be finalized was definitely, I'll go out and say it, an anxiety-inducing process. Like we're waiting for intel, we're talking to our lobbyists, we're hearing reports in the news when the budget's going to come out, and now it's here. And this conversation and many of these conversations allow us to make sense of what's going to come next. So as a reminder for everyone that attended, the webinar was recorded. We will be sharing the recording along with a recap via email. And this is our second event in our Public Health Under Pressure series. And we look forward to continuing these conversations, hopefully back in person in the fall. So take care, everyone, and thank you again for joining us.